5 medical checkups I'd never get after 70. A doctor explains why. Receiving a routine screening appointment from your healthcare provider is a common occurrence, and it's natural to accept these recommendations without much thought. For decades, the emphasis has been on proactive health management and catching potential issues early. However, after many years of medical practice focusing on the health and well-being of older adults, it becomes clear that some of the tests commonly ordered for individuals over 70 may, paradoxically, carry more potential for harm than benefit. It's a truth not often spoken aloud, but understanding this critical shift can profoundly influence your healthcare decisions. Many professionals in medicine dedicate their careers to helping people navigate the complexities of health as they age, distinguishing between necessary interventions and situations where it's better to observe or leave things undisturbed. There are several routine medical checkups that, for someone over the age of 70, would be approached with significant caution, not out of a disbelief in medical science, but due to a deep understanding of what can transpire when these tests reveal findings in an older body. The outcomes are frequently not what people anticipate, and they underscore a fundamental concept known as screening math. The rationale behind medical screenings changes dramatically once you pass the age of 70. When an individual is 50 years old, for instance, the logic behind screening is quite compelling. Detecting a small cancer or abnormality at an early stage allows for timely treatment, potentially adding decades of healthy life. The risk-benefit calculation in this context strongly favors screening. However, as one ages beyond 70, this equation shifts due to 3 significant factors. Firstly, many cancers and other abnormalities tend to progress very slowly in older individuals, often so slowly that they would never manifest symptoms within that person's remaining lifetime. In such cases, the individual would likely pass away with the condition rather than because of it. Secondly, the human body becomes more vulnerable and fragile with advanced age. Invasive procedures such as biopsies, surgeries, and even the anesthesia required for these interventions, along with the subsequent recovery periods, all carry a substantially higher risk for older adults. The body's resilience diminishes, making it more susceptible to complications and slower to heal. Finally, there is a phenomenon known as the cascade effect. This describes a chain reaction where one seemingly minor abnormal finding on a routine test can trigger a series of increasingly invasive follow-up procedures. This might begin with an initial test, leading to a more specialized test, then a biopsy, potentially followed by surgery, and ultimately, complications. This cascade has been observed to significantly diminish the quality of life for individuals who initially presented as perfectly healthy, transforming what was intended as preventive care into a source of harm. Routine colonoscopy after age 75. One of the first routine medical checkups that merits critical reevaluation after the age of 75 is the colonoscopy. Consider the experience of an active 78-year-old individual who regularly engaged in physical activity and felt completely well. Despite feeling fine, their previous healthcare provider strongly recommended a colonoscopy because it had been several years since their last one. Trusting the medical advice, the individual agreed to the procedure. However, the bowel preparation alone, a necessary step before the colonoscopy, proved to be extremely taxing. This individual experienced severe dehydration, which caused their potassium levels to drop dangerously low and triggered an irregular heartbeat. Ultimately, they ended up in the emergency room even before the procedure could be performed. It is important to note that the United States Preventive Services Task Force, USPSTF, a leading independent panel of national experts in prevention and evidence-based medicine, actually recommends against routine colonoscopy screening for average-risk adults after the age of 75. The existing medical data is quite clear on this point. For individuals over 75, the risks associated with a colonoscopy, including potential bowel perforation, adverse reactions to sedation, and severe dehydration caused by the bowel preparation, begin to outweigh the likelihood of finding a cancer that would meaningfully impact their remaining life. A bowel perforation, for instance, occurs in approximately 1 out of every 500 colonoscopy procedures. While this might seem like a small percentage, in a more fragile 78-year-old, such a perforation could necessitate emergency surgery, potentially leading to a colostomy bag, weeks of hospitalization, and, in some cases, even fatality. If you are over 75, have no specific symptoms, no family history of colon cancer, and a history of previous clean colonoscopies, it would be prudent to discuss with your healthcare provider whether a simpler annual stool-based test might offer a safer and equally effective alternative for screening. Aggressive breast and prostate cancer screening. The discussion around aggressive breast and prostate cancer screening in older adults can be quite sensitive, requiring a very precise understanding. The point is not to advocate against cancer screening altogether, but rather to highlight that overly aggressive screening in individuals in their late 70s and 80s frequently leads to overdiagnosis. This overdiagnosis, in turn, can result in overtreatment, causing more problems than it solves. What exactly does this mean in practical terms? For breast cancer, studies published in reputable medical journals have indicated that a significant percentage, up to 40% of breast cancers detected by mammography in women over 70, are what are known as indolent cancers. These are slow-growing tumors that would likely never have caused any symptoms or posed a threat to life during the individual's remaining years. However, once a medical report identifies the presence of cancer, a complex and often irreversible sequence of medical interventions is initiated. This typically involves further biopsies, surgical procedures, radiation therapy, and potentially chemotherapy. Each of these treatments carries its own set of side effects, which can be profoundly debilitating and even devastating for an older body, impacting overall quality of life without necessarily extending it. The situation is strikingly similar for prostate cancer, with the prostate-specific antigen, PSA, test being particularly problematic in older men. Elevated PSA levels are exceedingly common in this demographic, and in the vast majority of cases, they do not signify anything life-threatening. Despite this, an elevated PSA level often leads to a prostate biopsy. Prostate biopsies themselves are not without risk. Approximately 5% of cases result in infection, sometimes severe enough to require hospitalization. Should a biopsy detect a slow-growing cancer, which is a frequent outcome, the individual is then faced with the prospect of surgery or radiation. These treatments can lead to permanent side effects, such as incontinence and impotence, outcomes that can drastically diminish the quality of life for a cancer that in all likelihood would never have caused any issues. Consider the experience of an 81-year-old retired teacher whose slightly elevated PSA during a routine visit prompted a biopsy, revealing a low-grade prostate cancer. The subsequent recommendation for surgery led to the teacher regretting the initial PSA test 6 months later, as he was dealing with continuous incontinence. His particular cancer was one that, given his age, he would almost certainly have died with, not from. If you are over 75, it is critical to engage in a detailed discussion with your doctor, asking, if this screening identifies something, what would the actual course of action be? And would that treatment genuinely enhance my life or simply prolong anxiety and introduce new complications? Routine cardiac stress testing. Among the various routine screenings, cardiac stress testing in asymptomatic older adults poses a unique concern because it initially appears so sensible. A healthcare provider might suggest, let's just get a routine check on your heart's performance. This typically involves either exercising on a treadmill or receiving an injection of a chemical that chemically simulates the effects of exercise on the heart. On the surface, this sounds entirely harmless and proactive. However, the fundamental issue lies in the high rate of false positives associated with these tests. Cardiac stress tests conducted on individuals who are not experiencing any symptoms can have a false positive rate as high as 40% in certain populations. This means that almost half the time the test results indicate that something might be amiss with the heart when, in reality, there is no actual problem. A false alarm, unfortunately, is not a benign outcome. It typically triggers a more invasive follow-up procedure known as a cardiac catheterization. During this procedure, a thin, flexible tube is threaded through an artery, usually in the groin or wrist, and advanced into the heart. Cardiac catheterization carries its own set of very real risks, including bleeding, damage to blood vessels, and in rarer instances, the procedure itself can precipitate a heart attack or stroke. Furthermore, if the catheterization reveals a partial blockage in the coronary arteries, a very common finding in nearly anyone over the age of 70, the individual might then be advised to undergo a stent placement. However, numerous large-scale studies, including significant trials, have demonstrated that placing stents in patients with stable heart disease does not reduce the incidence of heart attacks or prolong life when compared to managing the condition with medication alone. Therefore, an individual might start out feeling perfectly healthy, undergo a stress test, then a catheterization, receive a stent, and be placed on blood thinners with their inherent bleeding risks, only to find themselves statistically no better off than if they had simply continued their prescribed medications and maintained an active lifestyle, such as regular walking. If you are not experiencing chest pain, shortness of breath, or any other cardiac symptoms, a routine stress test is essentially venturing to find trouble where none exists. And in the field of medicine, when one actively seeks out problems in a 75-year-old, it is almost inevitable that something will be found, even if it is not clinically significant. Routine bone density scans. The suggestion of routine bone density scans, or DEXA scans, often brings to mind the critical importance of preventing osteoporosis and the devastating impact of falls in older adults. It is undeniable that falls are a serious concern, leading to significant morbidity and mortality in the elderly. However, the logical chain often breaks down in the subsequent management. A DEXA scan might reveal low bone density, leading a healthcare provider to prescribe a bisphosphonate medication, such as alendronate. Patients may take these medications for years, yet ironically, long-term use of bisphosphonates has been associated with an increased risk of atypical femur fractures, precisely the kind of debilitating break these drugs are intended to prevent. Beyond this, these medications can also cause severe deterioration of the jawbone, a condition known as osteonecrosis of the jaw, which is excruciatingly painful and notoriously difficult to treat. In contrast, the most effective intervention for preventing fractures in older adults is often not a pharmaceutical one. It is a comprehensive fall prevention strategy. This includes incorporating regular balance exercises into one's routine, actively removing tripping hazards like throw rugs from the home environment, installing grab bars in bathrooms and other high-risk areas, ensuring regular vision checks and updating prescriptions as needed, and meticulously reviewing all medications to identify and mitigate those that may induce dizziness or unsteadiness. These seemingly simple non-pharmacological steps have been proven to reduce fracture risk more effectively than any medication, and they come without any of the associated side effects. If you have already undergone a DEXA scan and are currently on medication for bone density, it is crucial not to discontinue it without first consulting your healthcare provider. However, if your doctor suggests a routine DEXA scan and you have never experienced a bone fracture, it is entirely appropriate to inquire whether investing your time and energy into a proactive fall prevention program might offer a more beneficial and safer approach. Routine carotid artery ultrasound screening. The concept of routine carotid artery ultrasound screening often appears logical and appealing, yet it can be one of the most perilous. This test involves using an ultrasound probe on the neck to examine the carotid arteries, which are major blood vessels supplying blood to the brain, in order to detect any blockages. The discovery of a 60% or 70% blockage can sound incredibly alarming and typically prompts a referral to a vascular surgeon. This can then lead to a recommendation for a carotid endarterectomy, a surgical procedure designed to clear out the detected blockage. However, a significant problem arises when individuals without symptoms undergo this screening. If you are asymptomatic, meaning you have experienced no mini strokes, transient ischemic attacks, no episodes of vision loss, or any other neurological symptoms, the surgery intended to prevent a stroke carries a substantial risk of actually causing the very stroke it aims to avert, with a risk ranging from 2% to 3%. In older adults, this risk is even higher. The USPSTF explicitly recommends against routine carotid artery screening in asymptomatic adults. Their comprehensive analysis concluded that for patients who do not exhibit symptoms, the potential harms of the surgery, which include stroke, heart attack, and nerve damage, outweigh any potential benefits. Consider a family's distress after their 79-year-old father underwent carotid surgery following a routine screening. Before the surgery, he was fully mobile, articulate, and living independently. Post-surgery, he suffered a stroke that permanently impaired his ability to speak clearly. The blockage that was addressed had been present for years and likely would have remained clinically silent, but the surgical intervention to fix it tragically resulted in the very catastrophe everyone feared. The 4 Questions Protocol. To empower yourself in these critical healthcare discussions, there is a practical 4 questions protocol that you should commit to memory. Jot them down, save them on your phone, and bring them to every doctor's appointment moving forward. 1. What exactly will this test look for, and what happens if you find something? This question aims to understand the specific scope of the test and, crucially, to anticipate the immediate next steps if an abnormality is detected. It helps you understand the full path, not just the initial screening. 2. If you find something, what would the treatment be, and what are the risks of that treatment at my age? This delves into the practical implications of a positive finding. It prompts a discussion about the proposed interventions, allowing you to weigh the potential benefits against the specific risks, which, as discussed, can be significantly higher for older adults. 3. What happens if I don't get this test? What's the actual risk of doing nothing? This question helps to quantify the risk of inaction. It allows you to understand the natural progression of a condition if it goes undiagnosed or untreated, providing a baseline for comparison against the risks of testing and treatment. 4. Is there a less invasive alternative that gives us useful information without the same level of risk? This encourages a search for safer options. Many medical conditions can be monitored or assessed through less aggressive means, and this question opens the door to exploring those alternatives. Any healthcare provider committed to patient-centered care will welcome these questions and be prepared to discuss them thoroughly. If your doctor appears annoyed or dismisses your concerns, that interaction itself conveys important information about the communication style and patient involvement in your care. It is absolutely crucial to be clear. This guidance is not an endorsement of avoiding all necessary medical care or ignoring symptoms. If you notice blood in your stool, a colonoscopy is absolutely warranted. If you experience chest pain, a stress test is a vital diagnostic tool. If you have experienced a mini stroke or any other neurological event, having your carotid artery checked is unequivocally necessary. The presence of symptoms fundamentally alters the risk-benefit calculation for any diagnostic procedure. What is being emphasized is that routine screening, the kind where you feel perfectly healthy, but your doctor suggests, let's just check, carries a significantly different risk-benefit profile once you are over 70. You have an inherent right to be fully informed about this distinction. For many years, we have observed individuals enter routine screenings feeling healthy, only to embark on the cascade effect and emerge feeling unwell or broken, not due to medical error, but because the prevailing medical system is often designed to find problems and treat them, irrespective of whether that treatment genuinely enhances an older individual's quality of life. You possess the right to ask probing questions, to comprehend the associated risks, and crucially, to assert your autonomy by saying, "Not right now," or even simply, "No." Ultimately, it is your body, your choices, and your life.